Okay, it's about 5 minutes after 2 Eastern Standard Time. It's January 12th, 2014. My name is Randy Wong. I'm a vitreoretina specialist in Fairfax, Virginia. Thank you all for joining me for my second webinar on frequently asked questions about FOV, frequently asked questions about floater-only vitrectomy. Um, as we've done in the past, I think it's best if you type a question as I'm speaking. And I think what I'll do is I'll go over the questions. We'll have a Q&A session at the end of the slides. There's really not that many slides. But that way I think it goes a little bit smoother and faster. I had thought about unmuting everybody, but apparently um, GoToWebinar does not suggest that because it kind of overrides the or compromises the audio quality. Um, so let's just go back to I'll be speaking, and then if you have questions, go ahead and type them in, and I'll answer them in order. Okay. So anyway, thanks for joining us this afternoon. Um, let's get started. So as many of you know, I'm a vitreoretinal surgeon. Uh, I practice in Fairfax, Virginia. I have two websites, which I'm very proud. One is retinaeyedoctor.com, and I started that about 4 years ago to augment my practice and really talk about all aspects of vitreoretinal disease. Over the last 2 years, it's been apparent that I needed to subspecialize in terms of my web presence, and we started vitrectomyforfloaters.com over the last 3 or 4 months. What I found is that there's a lot of energy in the floater world. There are many forums that I would like to participate in, but I don't really think it's my place as a physician to invade the floater forums, which I guess I feel are really should be reserved for the privacy of patients. But regardless, I started vitrectomyforfloaters.com as my kind of objective safe ground for all of us to have um, objective and constructive discussion about floaters. I would encourage all of you at the end or during this to please go to vitrectomyforfloaters.com and sign up for my email subscriber list. That way you get updates anytime we've got a new article relating to floaters, their evaluation and treatment. If you've been following me for a while, you know I've got 5 kids. I love Dunkin' Donuts, black please. I love to play tennis. Can't really stand to play golf, although I love to watch it on TV. Got two Labradors. I think they're the best dogs in the world. They are my fifth and sixth Labradors since I've been a kid. And I spend most of my time focused on my children, 3 of which have been huge ice hockey players. So most of you, if not all of you, are here today because you've got floaters and it's been interrupting or decreasing your vision. It's been a problem for months to years, or in some of you, even a lifetime. The unfortunate aspect about having floaters is that you've been discounted or ridiculed by the same people that should be out there to help you. That is, most of the doctors that you've consulted or other health professionals have told you to get used to the floaters, kind of grow up, or you're crazy because these are things that don't exist. As a result, you've been frustrated, and I think a lot of you humiliated. Compounding all this, there's no reliable information source on floaters anywhere. And my purpose in creating retinaeyedoctor.com and vitrectomyforfloaters.com and having these webinars is to have a place where you can obtain good information about your eyes, specifically about floaters and vitrectomy. So, as Chrissy likes me to say, to my word, on this forum or others that I participate, you will never be discounted as to your complaints of floaters. So today I'd like to talk about frequently asked questions about FOV. And Chrissy, I didn't add the part about refraction, but hopefully remind me at the end. The reason is I didn't want there to be too much of a difference between today's talk and the talk we gave 5 days ago. So these are the questions that we're going to review today in addition to refraction. But what is FOV? What is a PVD? Risks of FOV? Does FOV cause cataracts? What is Frill? Does previous retinal disease make me less of a candidate for FOV? If I come and visit you, Dr. Wong, how long do I have to stay? And what are the logistics to arranging a visit? What is the pre-macular bursa? Is intraocular gas used? What about inducing a PVD? A small and short word about ochroplasmin, and then, if I can remember, a statement about refraction and FOV. Again, I'm going to ask you to simply type in questions as we go along, and at the end I'm going to have a Q&A session, and I promise to get through all the questions as best I can. So what are floaters? Floaters are any opacity or anything within the vitreous gel which causes a shadow on the retina or blurs the vision. And here's a great illustration of floaters which are suspended right in the middle of the vitreous. And because the gel, or the vitreous is a gel, eye movement causes these floaters to move to and fro with eye movement. And that's a very important factor for me in determining whatever you're seeing, how it's a very important factor in confirming that it indeed is in the vitreous. Basically, anything that causes optical changes within the vitreous, which causes the vitreous to refract light differently. Those are floaters. FOV, or floater-only vitrectomy, is not a special operation. It's also been known as floaterectomy. To retina specialists, we call FOV a simple vitrectomy. FOV is simply a vitrectomy. A vitrectomy is the core operation or the basic operation performed by a retina specialist like myself, and it's used to treat a variety of eye problems, not just floaters. So FOV is not a special operation. Instead, it's a routine procedure performed for a special circumstance, and in this case, it would be floaters. Here's a nice illustration of a vitrectomy. Instruments are introduced to cut away the vitreous. By definition, floaters are located in the vitreous. The vitreous is a gel composed of protein and water, and the vitreous is not needed and is replaced by saline during the operation. Your own fluid or your own saline replaces the artificial fluid supplied during the operation. This happens in about 24 to 48 hours after the operation. By definition, the vitreous is needed for embryologic development of the eye. Once we're born, the vitreous really serves no purpose. What is a PVD? A PVD stands for posterior vitreous detachment. And if you see in the illustration here, this illustrates the vitreous, which is mostly adherent, especially on the sides. If you can follow my cursor, where the vitreous is adherent to the retina. In the back here, or on the posterior face of the vitreous, it's being separated from the surface of the retina. So this separation is called the posterior vitreous, and it's detaching or separating from the surface of the retina. It eventually occurs in everyone, meaning this is a normal event. When it happens, it's commonly associated with floaters. However, there are other things that can be associated with the sudden development of floaters. So you can't assume that new floaters are related to a PVD. So you must get it checked out, because there could be some real problems with your retina and the only symptoms are new floaters. However, for floaters that have been examined and are benign, vitrectomy is highly successful, if not completely successful, in removing them. What are the risks of FOV? The risks of FOV or vitrectomy are the same as any intraocular surgery, such as cataract. The risks that I fear most as a doctor are blindness, blindness from infection, or blindness from retinal detachment. Now, contrary to what many of you have been told, the risks or the chances of this happening are excruciatingly small or rare. The chances of infection is probably less than one chance in 10,000. The chance of retinal detachment may be 1 to 2%. These statistics are actually better or the same than if you had cataract surgery. The risk of infection, blinding infection in cataract surgery is somewhere around one chance in 2,000, and perhaps the chance of retinal detachment is the same as vitrectomy, being about 1 to 2%. You can have other problems with vitrectomy, such as high or low pressure. There can be bleeding, but the real risks that I worry about, again, are permanent blindness. Risk of cataract can also be a risk of vitrectomy. And I think for our purposes today, I'm going to go out on a limb and say that I don't believe that FOV or vitrectomy only for floaters really influences the development of cataract unless you have significant cataract at the time of the operation. And we can talk about that in a little bit more detail in a few minutes. Oh, here we go. Does FOV cause cataracts? And again, my answer is going to be no, but I'm also going to be worried that if there are pre-existing cataracts at the time of surgery, and remember, everybody gets cataracts, with or without vitrectomy, with or without FOV, as we get older, cataracts are a fact of life. My analogy that you see at the bottom is that everyone gets cataracts just like gray hair. Most of the time we get gray hair as we get older, but many times if you see a young person with gray hair, it doesn't really look that abnormal. Same deal with cataracts. Generally, cataracts occur in everyone as we get older, but it can occur in younger people as well. Some babies are born with cataracts. The real question is, does the vitrectomy only for floaters cause cataracts? There is no study I'm aware of that proves, there are studies that suggest, but there's no study that proves only FOV causes cataract formation. In my experience, in young people that have FOV, cataracts do not form in the ensuing 1 to 2 or 3 years. Keep in mind that vitrectomy is done for many, many reasons other than just floaters. If you take vitrectomy for all reasons, including vitrectomy to fix a retinal detachment, vitrectomy to repair a diabetic patient, to vitrectomy to repair a macular hole, those are instances where there are other complicated aspects of the surgery, such as injecting gas or air, or may have these surgeries are much longer than FOV. Increased surgical time and gas certainly does cause or create cataracts. Now, the studies that are out there, to the best of my knowledge, combine vitrectomy done for all reasons. There is one study that seems to implicate FOV only. However, that's a retrospective study, which is not the best type of study to look for meaningful data. So my stance is that, number one, you're going to get a cataract number no matter what. If you're young and have no evidence of cataracts at the time of this 10-minute procedure, then I don't think you're going to get cataract at all. Here's a good schematic of cataract. The cataract is normally clear. Here it is kind of brown or yellow in color. It's about the size of an M&M, and light has to pass through our pupil and go through this M&M or this lens and then gets focused onto the retina. If this is too dense or it's too brown, it becomes very difficult to get light through and focused on the retina. These illustrations, by the way, are supplied to me by Mark Erickson, who owns Jira Design. He is probably the foremost ophthalmic illustrator in the world, period. What is frill? I'm not exactly sure anyone knows what frill is, but frill develops after FOV And frill seems to be noticed only by young people, and it seems to be noticed only after successful vitrectomy. It is not a complication of FOV. In my opinion, frill may be residual vitreous, which has never been optically clear. And now that the central or core vitreous has been removed after vitrectomy, there is a contrast between residual vitreous and non-vitreous. It's very difficult to confirm because as a doctor, I can always see your vitreous. So I can never tell whether or not what you're seeing or what a patient is seeing. I can never confirm whether it's floaters or frill. Based on its description, based on who complains, my best guess is that patients have had frill and floaters all their life. Frill being defined, however, as not optically clear vitreous. Once the floaters are removed, now we discover that there's a second problem. Of the 20,000 or 15 or 20,000 vitrectomies I've performed in 23 years of practice, I have never had a patient complain of frill in whom I've done a vitrectomy for reasons other than floaters. That is, it's not a common occurrence if you take all vitrectomy. So I think it's a special occurrence in young patients that have or develop floaters. I do have a patient who's upset because the frill developed after FOV. We also keep in mind that neither frill, if there's no permanent loss of vision, I think we're in good shape. Frill is a temporary condition as far as I'm concerned. Regardless, I've changed my stance. I am more in favor of inducing a PVD, uh, especially in young people, uh, because it will allow me to remove more of the vitreous than if a PVD is not. Does a previous retinal disease alter my candidacy for FOV? In general, no, it does not. Is as long as you are aware of things moving in your eyesight, uh, things that move to and fro with eye movement, I think that your previous retinal disease does not alter the decision to uh, consider FOV. I commonly get asked questions about from patients that have lattice degeneration or retinal holes or previous retinal detachment or even diabetes. If there's any question as to the unsuitability of these conditions, we can treat you during the procedure or before the procedure so that lattice degeneration, retinal tears, retinal holes are not an issue. So the answer to that question, again, is no, previous retinal disease does not preclude you from having FOV. John asks, what is the saline solution composed of? Just water and salt? Yes, it is a sodium chloride solution. Um, Out of the bottle, it's called sodium chloride or balanced salt solution or saline. It is very similar in composition to our own aqueous humor. Uh, Joseph asks about the Joseph Seebeck article in Retina. Um, that's the study which is a retrospective study. And the questions I have are how many different surgeons, what the criteria were, and um, how patients were graded preoperatively. But I think 24% is really, really high. As far as length of stay and logistics, if you're from out of town or if you're going to be from out of town, what we normally like to do is schedule you for surgery before you even show up on a Friday. And you may come in and get a pre-op exam either Wednesday or Thursday. If for some reason during that pre-op visit, I don't think surgery is wise or you don't think surgery is wise, we simply cancel surgery Friday and we part our ways. No harm, no foul. In most cases, however, we proceed with surgery, which is performed on Friday. You go home with a patch. The patch comes off the next morning when we see you for your post-op visit. We'll start some drops. In most cases, you've got complete unrestricted activity after 24 to 48 hours, after which you may drive, fly, or take a train home. If you would like to, or if you prefer to stay in town so that I do your immediate post-operative visits, I couldn't be happier. Just let Chrissy, Andrea, or Bridget know what your plans are after the surgery. But I find it completely satisfactory and practical for you to come in for basically 2.5 days, get surgery done, and then follow up with your own eye doctor at home. And as far as I'm concerned, it does not have to be a retina specialist. Your own optometrist or your own general ophthalmologist should be able to take your vision, take your eye pressure, dilate you just to make sure that your retina is not detached. Floaters in the premacular bursa. Floaters that are located in the premacular bursa are a concern only for those few doctors that perform YAG vitreolysis. Vitrectomy, this is not a concern for patients. This is not a concern if you're going to have vitrectomy done. The reason that the YAG or doctors do not like to perform a YAG on floaters close to the retina is that the YAG is a cutting laser and it delivers this energy via the laser beam. So if it's focusing on something close to the retinal surface, the fear is that this energy that's focused too close to the retinal surface can cause damage to the retina. The vitrectomy, on the other hand, should be kind of thought as a vacuum cleaner. You know, you can vacuum the floor without the vacuum actually scraping the floor. So vitrectomy is performed with suction, so we can basically remove anything close to and even on the surface of the retina. So the premacular bursa is something that's only a concern for those 3 or 4 physicians in the whole United States, none of which are retina specialists, that advertise about YAG vitreolysis. Is intraocular gas used in FOV? There are some physicians who use 25 gauge vitrectomy, which is sutureless, that put air or gas in at the end of every operation. I think this is unnecessary. It's unnecessary because it can increase cataracts. It's unnecessary because you have to keep a certain head positioning. It's unnecessary because in the situations where gas is used, you can't go home and you can't go in places where there's a change in altitude, like up in the mountains or up in a plane. This might answer Michael's question. How do you induce a PVD? If a PVD has occurred naturally, do you still need to induce for any remaining attached areas? Well, how do I induce a PVD? Let me first say that once a PVD occurs, either naturally or if it's induced, it doesn't need to be created again. It's an event that happens to everybody, but once it happens, it can't be undone, if you will. So creating a PV during the vitrectomy is done with suction. I will create suction around that part of the vitreous that's close to the optic nerve. And let me go back in just a second and show you. The intent is to separate the posterior vitreous from the retinal surface. There is a theoretic chance of increasing tears in the vitreous if this is not, there's an increased chance of causing a tear in the retina if this is not done properly. And a retinal tear, as you may know, can cause a retinal detachment. And as we said earlier, that's one of my most feared complications of any operation. The reason to induce a PVD is it basically allows me to remove more vitreous than if a PVD is not created or if it's not present. And therefore decreases, in my opinion, the chance of frill. Let me go back a couple slides. I don't know why this doesn't work. Just use these buttons. Okay, so here's a posterior vitreous detachment. And what I would do is stick my instrument here and start aspirating or creating suction around this part of the vitreous, because this part of the vitreous is least adherent compared to this part of the vitreous. So the idea is to create a separation and cause it to move forward, and thereby it lets me remove more of the vitreous. But to answer your question again, it's done by straight suction. It's done once. If a PVD is present at the time of operation, um, then the operation is even easier. Ochraplasmin, or Jetrea, is an intraocular injection. It was FDA approved within the last 18 months um, to basically chemically induce a PVD, and this was thought to be helpful in macular conditions called vitreomacular traction, or epiretinal membranes, or macular holes. There's been a lot of talk about the use of ochraplasmin or Jetrea in patients that have floaters. There's also been secondary questions as to whether patients with a PVD will benefit from ochraplasmin. I've used ochraplasmin for the last 18 months. I am underwhelmed with how well it works, especially in patients with pre-existing floaters. If you've already got a PVD, I don't think ochraplasmin is going to do anything. If you've got floaters without a PVD and the ochraplasmin does cause a PVD, there's no saying that the floater is going to be uh, any better um, or less noticeable after the ochraplasmin injection. It is quite likely or quite possible that the floaters actually become worse. So that's why I say if a PVD is already present, it's unlikely to cause any changes. The other thing that we kind of don't pay attention to is risks of the injection. Risks, as a retina specialist, there are several treatments I give by injecting straight into the eye. Um, a common one, or the most common, is Avastin. You may have heard of Lucentis or Eylea. We inject steroids, and now we inject ochraplasmin. In general, the chance of getting blinding infection from injection is about the same as cataract. So you've got about a 1 chance in 2,000 of getting a blinding infection from the injection itself, compared to that same infection occurring in vitrectomy, which is 1 chance in 10,000. So you have to be careful, because there's risks with everything that we do. And the risk of an infection is comparable to cataract, both of which have a greater risk of infection or rate of infection than vitrectomy or FOV. um, that is my last formed question. What I'm going to add is, what about refraction and FOV? Basically, FOV does not cause, or vitrectomy should not cause, a change in your refraction. I've seen several questions, or a common question over the last several years has been, should I wait before getting laser vision correction or glasses before or after FOV? And in theory, it should not matter. So you don't expect vitrectomy to make any changes in your refraction whatsoever. Um, that's what I have as far as my presentation. So I'm going to start to go down the questions. Again, go ahead and ask questions. Type them in the question area, and I'll go down the line and do my best to answer them. Oh, Chrissy would like me to mention to all of you from out of town that go to our website. We do have recommended hotels. One or two of them give a pretty decent rate, which includes breakfast. Some of the hotels also offer transportation to the surgical center. Again, these are on our website, and if you've got any questions, make sure to address them either to email or ask when you call Chrissy or Andrea or Bridget. Michael asks, how do I monitor for hypotony after surgery? How quick does hypotony need to be treated if detected? Excuse me. I've had one case where hypotony lasted 3 days. That was in a gentleman that pushed on his eye, I think in his sleep right after the vitrectomy. Generally, hypotony is something we look for the next morning. It's usually completely gone by 48 hours. We generally don't have to treat hypotony. I think there are others, or there may have been reported complications of permanent hypotony after vitrectomy. I think that we are missing something in those stories. It just does not happen. There can be complications or hypotony after surgery for retinal detachment or when gas are used, but those are completely different than what we're doing here. So to answer your question a little bit more specifically, we look for it the next morning by measuring your intraocular pressure. If it's normal by then there's virtually no chance of hypotony afterwards. Because we're using 25 gauge vitrectomy systems, sometimes the little sclerotomies, those are the little holes that we put in your eye, they don't close up real fast. They take a day or two to close up, but once they close up and they are sealed, then your pressure rises and there shouldn't be any issues with that. Michael asks, are there any specific concerns when performing the surgery on an unusually long eye, 30 plus millimeters? No, I don't think so. 30 plus, greater than 35, we have issues with whether or not our instruments are long enough. A 30 plus millimeter eye means that probably you're somewhere in the order of minus 11 or minus 12, and that's certainly in the realm of normal standards for operating. Just so you know that when people talk about the length of the eye, we're talking about the length or the distance between the surface of the cornea, which is where your contact lens rests, and the surface of your retina. And by definition, the longer this distance is, the more nearsighted you are. So a minus 30 eye is somewhere, I would say, not abnormally long, but longer than most, and that's a very nearsighted eye, but it should not pose any problems. Joseph asks, what about FOV in young people, perhaps 25 years old or younger? No questions. It's not a problem at all. I've actually operated on patients that are less than 18. I've got several of them. The only issue is getting proper consent from the parents. For me to operate on a minor, I insist that the legal guardian or parents travel with them to the office to ensure that we get the proper permission and consent. Chrissy reminds me that the retinaeyedoctor.com website has most of our hotel information. With time, we'll get our information transferred over to the vitrectomyforfloaters.com. Thanks, Chrissy. Keeping me honest. Tom asks, what are common complaints that you receive immediately after surgery and even a few weeks afterwards? Surprisingly, none. The only concerns that we usually have are the few patients that have had frill, but most patients are much happier immediately when the patch comes off. Vitrectomy is virtually painless. All I recommend is over-the-counter medicines. The patch usually keeps you comfortable, but once it comes off, it's been my experience that everybody sees an immediate change or reduction in the floaters. people are able to see that things are improved. There's usually some blurry vision for a couple hours of the first half day, but by 48 hours, everything should be back to normal. Initially, we had problems with the amount of dilation, but we've made some adjustments for that so that even the blurry vision from the dilation needed during the vitrectomy isn't a problem. John says, thank you for doing this webinar. Is the RD risk you mentioned 1 to 2% during surgery? What are the post-surgical risks, and how long does it last before RD risk goes back to 0? Retinal detachment is unlikely to occur during surgery. If it were to occur during surgery, it would be rectified. If retinal detachments occur after surgery, for two reasons. Either a tear is created during the surgery that I miss, or a tear occurs after the surgery. In either way, probably the risk it returns to 0 after about 4 to 6 weeks. Miriam says, as you claim, if vitrectomy for floaters has low or similar risks to cataract surgery, why are the majority of doctors so hesitant to do it? If you email me, I will give you the article that I'm referencing, but I think the nuances of 25 gauge vitrectomy have escaped certainly most doctors and many retina specialists. Not everybody routinely uses 25 gauge vitrectomy. And if it were not for 25 gauge vitrectomy, I'm not so sure that I'd be having this webinar now. The biggest reason that vitrectomy is now a possibility is because vitrectomy is safer. The complications are safer or fewer than cataract surgery because of 25 gauge. Let me back up a little bit. 20 gauge is the standard for vitrectomy when it was invented. 20 gauge uses fatter instruments or 20 gauge instruments. Recently, 25 gauge instruments were introduced. Those are thinner. Because these instruments are thinner, it makes the operation a lot faster because we have to do less cutting to allow the instruments to get in the eye. And at the end of the operation, we don't need to put sutures in. So this is a sutureless system because 25 gauge instruments are so small that we don't need to go through special efforts to start the case and then end the case. This translates to much more comfort and faster healing and faster or fewer office visits. Those nuances most people understand. The nuances, however, from a physics point of view in going to thinner instruments are completely missed by many, many doctors. I think it's probably safe to say that most of us attending the webinar this afternoon have heard of McDonald's. If you were to investigate, you would find out that McDonald's, the fast food restaurant, has fatter straws than a standard drinking straw. That's right, you heard this first on Sunday afternoon at our webinar. But the McDonald's straws are fatter because they allow you to drink faster and easier. That is, the amount of suction that you create or the amount of liquid that you can get into your mouth is much easier with a fatter straw. The fatter straw would be analogous to the 20 gauge vitrectomy system, where in this case it would be very easy to suck, for lack of a better term, to suck or aspirate the vitreous, and that would cause, or that can cause, a retinal tear. The thinner instruments would be very similar to drinking soda or even a milkshake with a coffee stirrer. A coffee stirrer is hollow, but the coffee stirrer is much thinner. Can you imagine drinking a soda through a coffee stirrer? It requires a lot more force and it would take a lot longer. So that analogy is why 25 gauge vitrectomy systems are safer. It has less ability or has less chance of causing a tear in the retina because it's harder to grasp or suck on the vitreous. So the short answer is that 25 gauge vitrectomy systems have far fewer chances of causing complications such as a retinal tear. So now we approach, or the chance of complications of causing from retinal tear are about the same as cataract. Vitrectomy, 20 gauge or 25 gauge, has always been safer than cataract in terms of endophthalmitis or intraocular infection. There is a third reason that most doctors won't recommend vitrectomy, and that is because when vitrectomy was invented in the late 70s or early 80s, only the sickest eyes had vitrectomy surgery. Many of those eyes, despite vitrectomy surgery, still went legally blind or worse. Many of those, when vitrectomy was invented, it was only performed for cases of retinal detachment and complicated patients with diabetic retinopathy. Both of those are common causes of permanent loss of vision. So that vitrectomy surgery, and retina especially as a whole, kind of got a bad name in that everyone associates vitrectomy with bad vision or dangerous surgery. In reality, when it was invented, it was reserved only for the cases that probably would have gone blind with or without surgery. Fast forward to 2014, vitrectomy is used much more proactively. It's used for many more retinal problems such as epiretinal membranes, macular holes, bleeding, floaters than vitrectomy was when it was first introduced in the 80s. Unfortunately, many of those doctors that were around in the 1980s are still practicing, and they don't know the differences that technology has allowed us to appreciate. So, for all those reasons, vitrectomy's got a bad name. So, great question, Miriam. Thank you. Joseph asks, Dr. Seabag and other doctors believe that FOV changed the concentration in O2 and thus lead to oxidation of the natural lens. Another solution with fewer O2 would maybe help to reduce the speed of cataract formation. Joseph, I agree that that's their explanation. It's a hypothesis, but it's complete conjecture. We still need to establish, and someone needs to do a study that is proactive or prospective, meaning, and so-called double-blinded, meaning the best study would be to have 100 patients with the same identical complaints, 100 patients that have floaters and have the same degree of cataract. And then we would randomize the vitrectomy to either solutions with varying O2 concentrations, if you will, and see if cataract is formed. Again, the only studies so far are retrospective, and these tend to be very weak studies in terms of establishing good criteria. I am aware of their hypothesis, and I applaud them for coming up for reasons for something that has yet to be proven. Tom asked for international visits. If a post-op is conducted by another doctor, have you or would you be willing to discuss any issues with them? Uh, Absolutely. I mean, if you're specific, if I've operated on you and you're my patient, and there are complications that arise from my care, obviously, or maybe not so obvious, I'd be happy to discuss those issues with your doctor. Eric asks, is any sort of sterilization regimen recommended or advised prior to surgery to reduce risk of infection, or is this not necessary given the actions you and your staff take to prevent this from happening? I do not have any special recommendations or practices before surgery. Some cataract doctors would like you to use antibiotic drops before cataract surgery. And again, cataract surgery is a riskier procedure than vitrectomy. One of the reasons retina surgery is so safe is that we've always got fluid getting pumped into the eye. So that means there's always fluid coming out of the eye when it has a chance. That means it's very hard for bacteria to go from outside to inside. And I think that's the reason that vitrectomy is at least 5 to 10 times safer in terms of infection. I'm not aware of any other prophylactic measures before eye surgery used to um, prevent endophthalmitis other than antibiotic drops. And if that's your fancy and if that's what you prefer, we can certainly do that for you. Once you get to the operating room for my surgeries, your eyes sterilized with a topical antiseptic or antibacterial is an it's a iodine and soap solution, and that your eyes actually bathed on that, and that is pretty much standard around the country. John asks, are you or will you in the future use 27 gauge instruments? Any other future developments in instruments or techniques that might make FOV even safer? Um, I don't know if this question is from the article that I wrote regarding the Alcon constellation system, but Alcon, which is one of the major manufacturers of the vitrectomy instruments that we use, was going to introduce 27 gauge instruments in November or December of 2013. That announcement has been delayed, it's my understanding, for about a year. The reasons, I'm told, are that the company can't keep up with production or the demand for 25 gauge. And Miriam, that's another question. Answer to your question earlier is that 25 gauge really isn't standard across the country yet. So that's another reason people don't really get the nuances. Um, Back to John's question about 27 gauge. 27 gauge, in theory, sounds like it might be safer than 25 gauge. Um, I'm mindful of the fact that when 25 gauge was introduced, there was tremendous software complications such that a recall was made on the original batch of 25 gauge instruments. Um, I'm not so sure that going from 25 gauge to 27 is necessarily going to make it any safer with regard to retinal tears. I think it may decrease the chance of hypotony at 24 hours, but again, that's an uncommon problem as well. That's a problem that can be easily addressed by putting sutures in at the end of the case if desired. So even if 27 gauge were suddenly on my doorstep tomorrow, I think I'd be very hesitant to use it, probably for at least a good year to year and a half, just to make sure at least the software and everything else were working well. The other issue that remains to be seen is how durable these instruments are in terms of stiffness, because this is again a thinner instrument, and we actually do need our instruments to be somewhat rigid or stiff. Uh, along that is another point is it has yet to be seen as to how well the vitreous can be cut with a tinier instrument. I think with 25 gauge, we've got an excellent balance of of everything. John asked, do retina detachments occur more in young patients because of the more rigid state of the vitreous? I would say that retinal detachments may occur as a complication of vitrectomy more often in young because the vitreous is probably a bit more tenacious and adherent to the retina. Overall, do retinal detachments occur more in the young? I would say it's pretty much equal. Tom asks, what are some of the reasons you might tell the patients they should not have surgery during the pre-op? If I'm not convinced that what the patients are complaining about, um, that they're actually complaining of some other visual problem that is not explained by the vitreous, that's probably the one reason. If I think there's a psychiatric problem where patient's not really responsible for his actions, or they have unreasonable expectations after the surgery, I think that might cause me to um, recommend that we don't operate. This rarely happens, um, but for obvious reasons, patients, we can't possibly commit to surgery without an exam. But in general, most patients do have surgery the next day. Tal asks, what are the chances to get frill after FOV PVD induced? I'm going to just say less than about 5 to 10%. It's pretty uncommon when a PVD is induced. Um, it's not. It's what, but when it does happen, it for some patients it's just intolerable, and that's why I have migrated, if you will, towards inducing a PVD. Miriam says, "Thanks for your thorough answer." It's probably too too thorough. In your experience, however, in a young person with no PVD, what's the cause of sudden onset of floaters? Have you found that they can be caused by stress, illness, medication, etc.? I don't always know the cause of sudden onset of floaters. If it's not related to a tear in the retina, young or old, the next possibility is either bleeding or problems with inflammation. Um, can they be caused by stress or medications? Not to my knowledge. Could it be caused by illness? Maybe if you had some systemic inflammatory problem, or a vasculitis, which could manifest in the eye. But those are pretty. That would be those things don't happen too often. But certainly it wouldn't be caused by stress, etc. Eric asks, can you talk about the use of sutures? How often do you use them for FOV? I rarely use them for vitrectomy, period, because I rarely need them. Um, if there is concern about the pressure the next day, then I have no problems putting 3 sutures, one for each hole, uh, in at the end of the operation. It's very easy to do. You just it, the doesn't even really change the postoperative course at all. Just takes a little bit of it. Just takes the extra time to put them in. Not a big deal. Um, if there are no other questions, that's the last question I'll have. I'll hang out for a couple more minutes. Um, I thank you all for joining in. I think this is a great way for doctors and patients to communicate. If you are compelled to come visit us in Fairfax, um, we look forward to meeting you. I'd ask that you either call Andrea at the number that you see above, or Bridget, or online you can email Chrissy. Those three kind of run my life between the two offices and my online. If you want to email me personally, here's my Gmail account. Again, I'd appreciate if you do several things. Go find us on Facebook, like us, because that will increase our readership. Promote us if you can on your respective forums. But if you do nothing else, I'd love to hear or keep in touch with you. And we can do that by if you subscribe to our email list at vitrectomyforfloaters.com. I'm going to stay on for just a couple more minutes in case you have any other questions. Um, if not, I'll be getting ready to adjourn in just a couple of minutes. But I thank all of you for participating. Miriam, you asked some great questions. Eric, it was great to see you again today. Tom and John, thank you for your excellent input and your energy. Michael, you've also asked some great questions. And Tal, it was very nice to meet you today. Joseph says, thank you. You're very welcome. Thank you. Um, I hate this question, Miriam. Um, how many floater only vitrectomies have I done? I've done 15 to 20,000 vitrectomies. Um, and that's kind of the best answer that I can give you. In the last 2 years, my rate of floater only vitrectomies have increased, only because word has slowly gotten out and that we do them in Fairfax. Um, I don't have an exact number. It's just one thing that I've never ever kept track of is my own surgical statistics. Tao says, thanks, you're welcome. Chrissy would like me to remind you, or she's reminding me that FOV is covered by insurance to the best of our knowledge, as it's considered medically necessary. Michael asks, are there any scleral scars left afterwards that could interfere with wearing of scleral type contact lenses? Is dry eye an issue for healing after FOV? The answer is no and no. Microscopically, you might be able to see a tiny scar, but this would only be visual. It would not be physical, and so it should not preclude, should not change the contour of your cornea or sclera once you've healed. Is there any dry eye issues for healing after FOV? No. Okay, gang, I'm gonna stay on for about another minute. It is 15:02, 3:02. I am also watching the 49ers play the Panthers. I don't know if any of you are watching football, but I gather I'm not the only one who's multitasking this afternoon. Tom says, I think it gives people with floaters hope that there is someone who specializes in floater removal, whether they intend to do the surgery sooner or later. Thank you for the webinar. Tom, you're very welcome. And all I can say is that there is a lot of hope. There is so much misinformation out there that people have either been um, truly believe that they're crazy because they've been discounted for so long, and then suddenly some guy, being me, comes along and says, "Well, it's a pretty safe operation, so I don't know why you wouldn't do it because it's safer than cataract surgery." And all of that's true. It's just taking a while for um, people to understand that. Everything I say is really factual. We're lucky that technology has improved it so far that we're actually, I'm giving a lecture in February where I'm talking about the safety of vitrectomy, such that for the first time in the history, a retinal surgeon, believe it or not, is offering or performing elective surgery, such as for epiretinal membranes or removing blood or for floaters. Before 25 gauge vitrectomy, we had to really kind of scratch our head and say, okay, are the plus and minuses going to balance out? Are the gains going? Are the gains? Do they outweigh the risks? And we're at the point now where finally vitrectomy actually is one of the safest eye surgeries that are out there. Joseph asks, do you know a good surgeon in Europe that can perform FOV? I don't. And I don't even know what European retina specialists need to get credentialed to perform vitrectomy. Miriam asked about pricing and surgery. I'm going to either email me directly and I will forward that email to Chrissy, Andrea, or Bridget, and we can follow up with that. We can also check out your insurance. Um, Thank you again for your help and understanding. Miriam, very, very welcome. And Miriam hopes that the football game goes the way I want. I'm lucky this year because I don't care. My team, which is the Washington Redskins, probably had their worst season ever since I've been a Washington Redskin fan, and that's been since the mid 1960s. I don't think we've ever had a this horrid season, but I pretty much like playoffs of any sport. Joseph says, bummer about knowing someone in Europe. But we have lots of reasons to come to the United States and visit so you can make it a memorable experience for you. Michael says, thank you very much for the webinar. Very informative. Nicely done. Appreciate the comments. Joseph, you're very welcome again. Chrissy, thanks for your help and attendance. Go Redskins. Well, gang, I wish you Happy New Year. I'm going to adjourn. Hopefully, we'll do this again, um, maybe in a couple of months instead of a whole year. Follow us on Facebook. Sign up for the um, email subscriber list, and please feel free to email Chrissy or myself if you have any questions. Hope you all do well. Have a great rest of the weekend. Thanks for participating. Best of luck.